Good afternoon. I know it's after lunch, and I know also that it's very difficult to keep, awake. But trust me, I'll try my best to keep you awake and go through this presentation. Honorable Chair, my dear colleagues, audience, on Thursday, we had a day-long meeting. It was a workshop on nutrition, nutritional issues related to anemia control, and also to the prevention and treatment of preeclampsia and eclampsia in developing countries. We dealt with calcium and then with anemia. And today, my job is to report to you what we discussed during the workshop. So briefly, what I'm going to do is to tell you about the about the evidence very briefly, and then I will go into the results of the exercise. May I have the slides, please? Thank you. So we now know that preeclampsia, eclampsia affects about 10% of all pregnancies, and the rates are higher in this part of the world. Whether it's related with malnutrition, low chronic energy deficits among women, whether it is related to inadequate intakes of calcium that we have discussed in the morning session. There was also a question about bioavailability of calcium from the diet that we take in this part of the world. But we know that by far, milk is the most rich source of calcium. And you can see from this table that even if you consume a huge amount of other vegetables, beans, the dark green leafy vegetables, you have to take quite a lot to come up to a quantity that is given by just 1 cup of milk. And that is why when we compare the intakes of milk products, which serves as a proxy indicator of calcium intakes, we see that if you compare the results with United States of America, where the intake is more than 250 kilograms per capita per day, you taper down as much as Bangladesh, where the consumption is no more than 16 kilograms per capita per day. And if you want to translate this into real intakes of calcium, again, this portrays a similar picture. United States, quite high, and then as you go down, Bangladesh, no more than 200 milligrams per capita per day. So this is reality. When we go on to search for evidence of intakes of calcium, this is what I found. Again, data from a study that we did a couple of years ago in rural Bangladesh from 2 sub-districts where we studied about 500 women of childbearing age. We extensively, meticulously looked for 24-hour recalls to have an idea about what they were consuming in terms of calcium nutrition. And we were very surprised and disappointed. And look at the figures, only 150 milligrams of calcium per day of intake by this woman of childbearing age. And that is why in 2008, when we worked for the Lancet series on maternal and child nutrition, we reviewed almost all the nutrition interventions globally. And we came across a list of interventions that we recommended to be implemented immediately across the 36 countries that bear 90% of all undernutrition burden in this world. And you can see here the 2 most important interventions seem to be iron folic acid in tablet implementation and maternal supplementation with calcium. We have heard this morning right from the author himself, Dr. Hofmeier, the results of the Cochrane review of calcium supplementation and its impact on preeclampsia and eclampsia. And we can see that the risk of hypertension is reduced with calcium supplementation to the extent of about 35%. Preeclampsia, almost 50% reduction. And the reduction is much more pronounced among women who have a very low intake of calcium in their diets to the extent of about 65%. And even then, preterm delivery was also reduced as a result of calcium supplementation, about 25%. Now, how does calcium fit into the picture of reducing morbidity and mortality among women and neonates? So this is the cartoon where the relationship with parathyroid gland is shown. We know that when a person has a dietary inadequacy, the serum calcium level goes down, and this exerts a feedback on the parathyroid glands. The parathyroid gland starts producing more of parathormone. There is also an increased secretion of another hormone, renin. As a result of this, the vascular intracellular calcium concentration increases. There is increased vascular resistance and vasoconstriction, as a result of which there is increase in blood pressure. So the question is, what is the way forward for introduction and implementation of calcium supplementation? Now that we know that yes, there is evidence of calcium supplementation in offsetting the very deadly impacts of diseases like eclampsia and preeclampsia during pregnancy. So this is a cartoon which in fact shows the way for a country which is about to introduce calcium supplementation. We are not talking about calcium scaling up. We found during the exercise done on Thursday that none of the countries actually had a national program. It was only Nepal that has started a pilot program on supplementing women during pregnancy with calcium. So we first need to see what is there in the policy, where is the finance going to come from. In case of Bangladesh, I can tell you that there is only one mention about the use of calcium supplements in our new nutrition operational plan. And that, of course, relates to osteoporotic disease, not due to eclampsia and preeclampsia in pregnancy. And again, if you look at the budgetary allocations, only 1%, and this 1% of the budget for nutrition is for other micronutrients. Other micronutrients include zinc, calcium, and many other things. And you can very well understand that in the fight for budgetary allocation, calcium will not stand against zinc. So then we have to look for a good strategy for behavior change communication, and then pre-service, in-service training, which is so essential, and I will touch down upon that. And finally, scaling up going on to achieve a good clinical coverage. Now, during the exercise, we came up with a lot of guidance principles, and I am going to briefly touch upon them. First of all, we need to advocate with the policymakers using global evidence. We know that within Bangladesh, within other countries, you may not have sufficient evidence. So whatever the evidence is available globally, we have this Cochrane database results, fantastic results in favor of calcium supplementation. We have to take those and go for a good advocacy. But at the same time, we need to have separate national policy guidelines and also guidelines on streamlining calcium supplementation into effective clinical protocols. We need to develop advocacy strategy to reduce preeclampsia, eclampsia. Cost. All of us, we felt that yes, cost was a major issue, because if you compare the cost of iron folic acid supplementation, which should be less than $1 for one episode of pregnancy, the cost for calcium supplementation should be close to $14-15 US. So we are talking about a differential about 14-15 times. And this can be too much for a national government in this part of the world. So we need to look at the cost. We need to look at the cost effectiveness of calcium supplementation. And it was also resolved that we need to discuss with the local pharmaceutical company if they can select a cheaper calcium supplement and start producing tablets at a much cheaper price. We also talked about training of volunteers and health workers. Nepal is a country which has got a classic example of piggybacking health workers, paid health workers with health volunteers. Perhaps we can take examples from Nepal. Logistics, one of the most important thing is how we can enter calcium into the list of essential medications. Perhaps in this field, we can be helped by USAID, UNICEF, and WHO. We also talked about raising the awareness of community health workers. This is very important, the health systems issue. And you will agree that in this part of the world, the ratio of health worker to population is abysmally low. So under this huge constraint, how can we make best use of whatever is available? And one of the ways would be to raise the awareness and the motivation of the health workers. Developing IEC materials, and this would focus on benefits to the child and the lowered risk of preeclampsia and eclampsia in the community. We need to carry out social marketing approaches for calcium. This is a country where social marketing has played an immense role in promoting oral rehydration therapy for the control of diarrheal disease. Indeed, one of the classic examples throughout the world. Perhaps we can again take examples from this wonderful social marketing strategy. Addressing misperceptions of health workers about calcium. We have heard that there are a lot of misperceptions, not just with calcium, which is a new kid in town, but also about iron supplements. Perhaps, they think that it can lead to other health hazards, it can lead to some problems with the babies. So these are the misperceptions that we need to alleviate, particularly among the healthcare providers. And the other most important thing is compliance. We note that there is a lot of poor compliance with iron folic acid tablets. So we also expect that there would be a compliance problem with calcium supplementation too. How can we take care of that? This is something we need to, discuss and take care of. Another subpopulation that was considered very important during the exercise was the adolescent girls and the newlywed women. So these are the people who also need to be informed prior to them becoming pregnant about the benefits of calcium supplementation. So generating country-specific information on calcium deficiency, because we heard that perhaps it was from Cambodia that they felt that no, there wasn't any calcium deficiency. Whether this is hearsay or based on solid evidence, that remains to be seen. Perhaps there are smaller studies lurking here and there. So we need to find out the results and try to put them into place for proper advocacy. Tracking through proper monitoring and evaluation, and this is equally important for other programs as well. And then develop public-private partnerships, which is, again, very important in order to promote this type of supplementation program. So the final research, the second last slide here is on the research part of this program. What we felt was that we need to conduct formative research on practices and understanding of preeclampsia, eclampsia, and also on the BCC strategy. If somebody comes up with a program, even a pilot program, we need to consider what sort of behavior change communication message should we have for the community. We need to develop different formulations of calcium through research. Should it be the calcium carbonate preparation? Should it be the citrate preparation? We need to think about the cost and other issues, the bioavailability, the absorption, the digestibility. And then we also need to have research on interaction between calcium and iron. Currently, we are aware of a development work in progress where they are trying to piggyback iron and calcium together, so much so that they won't interact with each other. And then, of course, on the optimal dose of calcium, should it be 1500 milligram as recommended in the WHO guidelines, or should it be much less? If it is much less, then it is better. We will have less cost and we will have to, do less with the logistics of carrying these heavy tablets. And finally, all the countries that were present on Thursday's workshop, we have been asked to fill out the country-level maps in our countries. This is a very important exercise that all of us we felt, and we are told that MCHIP will be following this up again in the coming 3 months so that at least the countries have a tentative plan on how to introduce calcium supplementation during pregnancy. So thank you very much.